significant neglect for this very common, very troublesome disease. I'm here, one of my roles is that I happen to be the clinical lead for COPD in the HSE Clinical Strategies and Programme Directorate, and this has been established for a number of years, originally under Dr. Barry White, and more recently it's Dr. Anya Carroll has taken over the directorship of it. And with regard to the COPD programme, the idea was to reduce morbidity and mortality from the COPD through a number of initiatives. Time doesn't allow me to go through them at the moment, but there's been three that I think perhaps are worthwhile bringing to the attention of members. One is the COPD outreach service. This allows patients who ordinarily would have been admitted to hospital with COPD exacerbations be dealt with at home, or maybe discharged home somewhat earlier than they normally would have been. This has been pioneered in Ireland by one of Professor McIlvaney's colleagues in Beaumont Hospital, Professor Richard Costello. But basically, the COPD program, attempted to roll out this program in 12 other sites around the country. We've had great success where it's got going. We've had to start in a number of places with limited staff because of the recruitment pause, and really we've been very much shackled by that. But in the submission, I mentioned the 12 hospitals that we have got going on that. The second thing is that primary care is an area where a lot of these patients could be dealt with. We've been looking at strategies to try and get spirometry out to primary care so the diagnosis can be made in primary care and these patients can be looked after in primary care. And the third thing is pulmonary rehabilitation, which is an integrated program for looking after patients with COPD. It primarily revolves around exercise, and this is hugely beneficial. It's one of the most beneficial things I do for my patients, and this is something we've been trying to nationalise and spread around the country. Cost effectiveness is important for this programme, and basically I think this, obviously with the events of yesterday bringing money to the fore again, we need to show that we're producing benefits for the taxpayer, and already the programme's demonstrated a reduction in the average length of stay for patients looked after with this disease in Irish hospitals. We've reduced the amount of bed day units required for patients with this disease in the hospital by a factor of 10,000 from 2008 to 2011. So I think we are demonstrating some return on investment to the taxpayer. So thank you very much for your attention.
Thank you very much indeed. And I want to, at this stage, just give apologies from Deputy Dennis Naughton, Deputy Caoimhín Ó Cualann, who has been replaced for today's meeting by Deputy Michael Kilreevy. Deputy Ó Cualann sends apologies. He's gone on a north-south meeting to Stormont, and also Senators Colin Burke and Senators Gillian Van Turnout. There are apologies for this morning. Okay, I'll call on Deputy Kilreevy.
Thank you, Chairman. And could I, first of all, thank you all very much for coming in today, and repeat the apologies for Deputy Caoimhín Ó Cualann, who normally sits on the committee here and who has a tremendous interest in the topic. He is in Stormont today looking at the health services from a north-south perspective, and he did ask me to sit in for him. I'm taken aback at some of the presentations here today, because, quite frankly, I wasn't aware of the level of lung disease and its prevalence in Ireland. Caoimhín probably would have been, because he would have been involved in looking at the studies. But I have a lot of questions. I commend the work that you're doing in highlighting this and in making the public aware of it, and in highlighting this and making government aware of the problems and the issues that are out there. My first question is, do we have any longitudinal studies to help us to understand why Ireland has the fourth highest rate of asthma in Ireland? Because that's a staggering statistic. Do we know whether the prevalence is increasing or decreasing over the last 10, 20, 30 years? Do we understand why 20%, 1 in 5 of our children suffer? Do we understand, or have we looked at why poor people, or people who are educationally disadvantaged or who have poorer educational levels, have 4 times higher level of the disease? I don't understand how the rate of prevalence moves from 20% of children to 10% of the general population, if I understand correctly, what has been presented to me. So that's in the area of understanding what's been presented in front of us. I ask whether people who suffer from chronic lung disease have automatic entitlement to GP, pharmacy and hospital services, medical cards. I wonder, is testing for chronic lung disease a part of the routine child health assessment programme that's done between a child is born and the age of 4? Or is there a test that can be applied to infants and younger children? Would it help if this were to be a routine part of the infant and child welfare programme? And do we have any information in relation to the impact, and I'm speaking both in terms of health, well-being and health economics, of early diagnosis and treatment of lung disease? And my final point for the moment is, there was little enough said about health prevention and promotion. Is this something that's hereditary? Are we giving up on it? Is it something we can do nothing about? Perhaps I've misheard or misread, but there wasn't a lot there in terms of prevention or promotion, apart from cigarettes. That's all for the moment, Chair.
Deputy, and Senator John Crown.
I'd like to thank my colleagues and sundry other allies for coming in today, and it's great to have the opportunity to hear your presentations. A few questions. First for Dr. Ed McCone. Ed, I mean, it is recognised that there are disparities in smoking across the socio-educational spectrum, but in addition to that, do you think there are other factors which determine the disparity in the incidence of lung disease across social groups? The next question I have for you is, how would we stack up in international comparisons in terms of the number of respiratory consultants per head of population? I would have a guess that we're probably somewhat worse than the UK and disastrously worse than any place else in the world. Britain and Ireland in general having disastrously low levels of specialists in most specialties. For my colleagues from the Asthma Society, it's frequently suggested that asthma is a disease where the advances in knowledge and advances in treatment have not necessarily percolated all the way down to the front lines of treatment, and that substantial further improvements could be made if doctors were to follow the best existing practices and the best medications. I just wonder what your take is on that in Ireland. Are we doing okay on that? For my colleagues from the Cystic Fibrosis Society, very quick question, one that was very topical here in this committee some weeks ago. Do you believe that an adequate number of beds have been built in the cystic fibrosis unit in St. Vincent's to comply with international guidelines for beds per sufferer in the population? And I'm very conscious collectively with all of you that you're right. You do harbour under somewhat of an extra burden because there is a perception that smokers are the people who get lung disease and it's their fault, and why should we spend any money if they just stop smoking? And of course it's a far more subtle and complex problem than that. But notwithstanding the fact that a huge part of lung disease is not related to smoking, if we were to have a complete disappearance of smoking as a habit, what would your estimate be on the percentage impact it would have on the demand for respiratory services across the country? And with respect to that, I'm asking you all to consider, when you go home, opening up your computers and looking at a website, SOS 2030, which is one that we have set up recently with the very ambitious plan of getting governments, the EU, the Commission, etc., to buy into the idea that we will pick a date in the future and say after that date it will not be legal to do for-profit commerce in tobacco. Thank you.
Thank you. And could I just again thank Senator Crown, not just for this meeting today, but also for being here despite having no sleep, so we appreciate that. Deputy Doherty, Regina Doherty.
Thank you. Thanks very much for coming in. And again, can I just concur with my colleague, because I had a view in my head this morning of what lung disease was, and it certainly isn't obviously anything like it's been presented to me, so thank you. I have a couple of quick questions that I can just dot around, please, if you don't mind. Ms Cosgrove, can I ask you 2 questions? Number one, you talked about the inequality of treatment on a national basis. What is causing that and what needs to be done to rectify it? Also, you said that there's certain parts of Ireland that don't have access to the drugs that other parts of Ireland do that are obviously of great benefit. Can you tell me why? Can I ask Mr Watt, please? You talked about the 13 adult beds that have been that are desperately needed in Beaumont. Where does that sit at the moment? Has an application been made for funding by your organisation to the hospital management? Has the application by the hospital management been made to the RDO? Has it even been applied for in the service plan? Was it ever in a previous service plan and just didn't get delivered? Where is that, please, if you don't mind? The Alpha One Foundation. Can I tell you, I'm not going to admit my age, but I'm not young anymore. I've never even heard of the Love Your Lungs campaign. Like, what are we doing wrong? And I don't mean you, but what are we doing as a Department of Health wrong to not, for everybody in the country to know how to love your lungs? I mean, we all know various other campaigns, and this one obviously seems to have missed. And when you look at the figures that are obviously far more stark than I would have considered, it's something that we need to do. So can you give me information, and please give us your advice as to how we can help, or the department can help, to get that campaign more exposure, please. Mr Smith, two questions, please. Number one, you talked about St Joseph's in Raheny being closed since last December. Why? Was it subject to a HICWA inspection?
Oh, sorry, yeah. Okay.
Sorry, was it subject to a HICWA inspection? Was that why it was closed?
I have no idea. I just heard.
No, we didn't answer the question.
Okay, right.
Sorry.
Sorry.
okay.
If you can tell me why. And also, you mentioned, and maybe I hope I picked this up right, apart from the statistics of what we have in male and female adults, that there's a growing number of children presenting. Why is that? Are we screening children more and that's why we're finding them? Or is there another reason as to why it's occurring in children that we didn't know beforehand? And can I actually ask you, it's probably a silly question because there mightn't be just one answer to it, what actually causes it? Is it different cause in adults than it is in children? Is it something that we bring upon ourselves? Is it something that we're born with? Can you tell me just briefly maybe, or point me in the direction of where I can find more information as to what causes it? I'm sorry, I didn't catch your name. Thank you. Can I ask you, you talked about the bad reputation that the patients have that suffer from COPD. We obviously need to change that. So what can we do to change that, particularly in the view that you said that even people who have reformed, I understand and appreciate obviously that the vast majority of people who get it are either smokers or former smokers, but are we still treating and castigating people who've been brave enough to give up, but just 20 or 15 or 30 years later still catch COPD with the same awful brush? And actually, I don't even think we should be treating people with the awful brush. You know, most people who smoke don't want to smoke and find themselves in the difficult situations of not being able to give up. So this kind of treatment, I think, is unfair. How do you think we could change that? Thank you.
And Deputy Catchenburn.
Thanks, Chair. Thank you very much. Well, thank you very much for all your presentations. I think it's a pity you all had to come in together because there's a lot of information there. And I'm just going to kind of look at two because some of the questions have been asked. I suppose for the first speaker about lower education levels, people living in lower social backgrounds, probably diet and everything else. Would you be able to kind of broaden that, just give us a little bit more information on that? I would be very interested in that. It astounds me that the Asthma Association, that one person dies a week from asthma attack. I didn't realise that. And I suppose as somebody who has dealt in the past with City Council, I'm still astonished at the stage that I deal with a lot of people who have housing difficulties, housing queries, and asthma is not registered as a medical condition with the local authority. If there's water running down your walls and the dampness has got over your head, it's still not classed as being living in poor conditions. And I find it astonishing when I go to any of the housing sections in City Council where a medical officer can say that conditions people are living in, particularly very bad conditions in a lot of the old flat complexes, don't add to the serious illness of asthma. So I just wanted to say that. I suppose for somebody who's had the trauma of losing a loved one and having to, well, they've had the donor card and having their organs donated, I think it's a terrible traumatic time for the family in general. And I think the only comfort people have at the end of it is after a couple of months, maybe even after a couple of years, is maybe the loss of that one that they loved has led to giving life to other people. And on that, I'm just really concerned about the whole thing about how people view being a donor, particularly how it's pictured. How do you advertise people wanting to be? I know you can tick a box on your driving licence now and you're regarded as being a donor, but I think you have to be a little bit more user friendly. I think you need to go into schools, you need to talk to young people, you need to go into colleges. Not everybody dies in road accidents. We just happen to have a family member that did. But I think there's a huge link with young people now. If they know if they're given proper information. And I suppose one of the things that struck us when we were left with that dilemma was, do you sign this piece of paper? Do you make that thing that maybe if you leave the people in the coma state that they are in, that they might come out the other end? Because we do hear of stories now and again. And I think that has to be a part of the education of asking people to be donors, how sensitive the tests are, and that when somebody says to you, there's nothing there, that you need to be able to take that in as an individual. And I think that goes for people wanting to be donors as well. So if you have any, I'm sorry for going on, Chair, but if you have any evidence of being able to portray people wanting to be donors, I think it's very important that that message goes out to young people, particularly, that, you know, and the families. And it needs to be in colleges and schools and in workplaces like here. Because I don't think a box on a counter in a shop asking you to take a card is enough for me. I think it needs to be something else more than that.
Thank you, Deputy. Deputy Sandra McLaren.
I'll
take all the speakers and then we'll come to the questions, just because to be fair to members who are here.
I'd certainly like to thank you all for coming in here this morning. Like other speakers before me, I had a different perspective as to what lung disease was. I suppose in my naivety would have thought that most of it would be down to smoking. Most of the questions have been covered, but with regard to the COPD, the narrowing of the airways, that it's different to asthma. You know, you were talking about running an awareness campaign, but you did say that only 50% of GPs surgeries actually can diagnose this. So even if you do run the campaign, you know, and people go to their GP, which they generally go to the same GP, how do they get diagnosed? With regard to alpha-1 and the hereditary emphysema, you said that there are 1 in 25 carriers in Ireland. Is there a database of carriers, and how do people know they're carriers, and how do they go about early detection?
Thank you. And finally, Deputy Mayor Mitchell O'Connor.
Thank you very much. Thanks for all your presentations, and whoever will answer the question. I just, you know, you've talked about Love Your Lung campaign, sleep apnea, all the various different diseases and illnesses you've brought up. And I just wonder, have you got evidence that what has worked in other countries? Like, you know, if you run a very good campaign and Deputy Doherty said she never heard of it, I didn't either. So there's something wrong, and, you know, it's probably our fault as much as yours. But what can be done, and what can we do in here to help you? And I also want to say thank you very much to Professor Crown for informing this Health Committee today about lung diseases. Thank you.
Thank you. Any other member? Okay. Who wants to kick off? Dr. McEwen?
Okay, I suppose I'll start with two issues that were raised. The first one was related to socioeconomic factors and the impact it has on lung disease. And I think that is certainly worth elaborating on. And then Professor Cran asked a question regarding staffing and manpower. As I mentioned, lung disease is much more common in people from lower socioeconomic backgrounds. And in the past, that has been largely attributed to people who are poorer from lower socioeconomic backgrounds tend to smoke more. I think we've a lot of information that shows that although smoking is an important contributor, it certainly is not the biggest one. And I suppose the most compelling data is firstly is that diseases that are not related to cigarette smoking. In particular, asthma, including cystic fibrosis as well, are heavily influenced by socioeconomic factors. Survival around the world is much, much lower. In North America, if you don't have private insurance, inner city asthma is a massive problem, and it's not smoking related. It's due to asthma and due to other environmental factors there. So we know the socioeconomic factors independently affects conditions like asthma and COPD, or asthma and CF. For COPD, our own data, and this is Irish data that we collected on World Spirometry Day in June of this year, we did free lung function testing. We offered it around the country. We had 750 people who came and had lung function testing done. Half of those had never had a diagnosis of lung disease ever in their lives. And of those, 1 in 7 had airflow obstruction suggesting asthma or COPD, and 1 in 5 had abnormal lung function. So again, just highlighting the prevalence of this condition. But we also asked people questionnaires regarding smoking habits and also their educational background. And just to reinforce, the educational level is actually one of the best determinants of socioeconomic background. It's better than asking people about their income or their jobs. So educational level is very, very helpful in predicting that. And what we found was that lung function on average was lower in smokers, as you would expect, but there was an independent effect that socioeconomic factors had on lung function, and obviously there was a significant lower level of lung function in people with who'd only get educated to junior cert level. Now, it's clearly not simply an educational issue. There's a lot of factors that are tied in with this, including awareness, and that's been mentioned repeatedly today, that getting the message out there that these symptoms people have, actually, you should do something about them. Access to healthcare is another issue. I mean, we have a good public health service, but there are limitations, and people and access can be a little bit disparate. There are certainly environmental factors as well, and I suppose as was mentioned, you go to housing, exposures, the type of jobs people have as well, the jobs that involve exposure to dust, fumes. These are the things that all cause lung disease that are not related to smoking as well. And in addition, even conditions like healthy air, that you're living in a poor environment, maybe in the centre of a city with a lot of traffic, you're exposed to more pollutants. So these are the sort of multitude of factors, and I will admit that we would like to do more work on that. I think that when you look at outcomes that for people from different socioeconomic classes, we spend a lot of money on drugs, that if you could find a way to bridge those outcomes, you could probably have a much bigger impact than a lot of the money that we spend on medications. And I think that's an important point. To then just move on maybe to the second question regarding manpower. There are 50 public consultants in respiratory medicine in the country. Looking across Europe, and there's actually a white paper coming out from the ERS later on this year, we try to get access to the hard data. We don't have it yet, but as Professor Crown mentioned, we fare very badly compared to other European countries in terms of delivery of respiratory health care. And that includes consultants, that includes respiratory nurses, that includes respiratory scientists, physios, and as well as primary care. To give it a number, currently there's about one consultant for about every 80,000 in Ireland, where in the UK it's about one for every 50,000, and they're actually looking to decrease that number. They're looking for more. And I think to equate to what number of consultants they would have in the UK, we'd be looking at an additional 30 consultants here. In terms of respiratory nursing staff, which are critical for doing the breathing tests that have been mentioned here to identify lung disease, we would also need to see a substantial increase in those in the hospitals. But this, I think, is being addressed by the asthma programme and by the Professor McDonald's COPD programme.
Okay. Sure.
Address your question on Alpha-1 and detection programs. So with regards to Alpha-1, we have a very good idea about how many people in Ireland have Alpha-1. We estimate that 170,000 people in Ireland have the MZ form, and over 3,000 have the ZZ form. Now, what does that mean? If you're a ZZ, if you smoke, you'll get severe emphysema in your 30s and 40s. Even if you don't smoke, you have a good chance of getting emphysema. The advantage of our targeted detection programs, our programs to detect this condition early, is that we know from our own data that if you're detected with this condition, we can get you to stop smoking, and we can institute a lifestyle change that will help prevent progression of disease. And so what we have done is we have set up a targeted detection program in Beaumont Hospital, which is funded by the HSE. Now, the funding has been cut, but it's still functional. And what we can do is offer a free test to everyone in the country. So everyone in this country can get tested free gratis for alpha-1 antitrypsin deficiency. We have rolled this program out to over 26 hospitals throughout Ireland and to GP surgeries. So if you're a GP in West Cork, you can send a letter to us in Beaumont. We'll send you with a kit. You can take a blood sample from your patient, put it on a filter paper, dry it, and send it to us, and we make the diagnosis. And not only that, we'll then give you a place, a place in our outpatient setting in Beaumont Hospital, and we'll give you a full workup on your alpha-1 and a lifestyle improvement pro forma that will help you. And the data is, if we can detect this condition early, we can preserve lung function, we can prevent deterioration leading to lung transplant, etc., etc. And probably more importantly than that, it's a good example of a public system that works. Adults and children. And the reason that it's important for children, if you look at alpha-1 antitrypsin deficiency in children, 10% of severe alpha-1 presents in childhood with severe jaundice. Of those children, 1/3 will require liver transplant in the first year of life. So again, early diagnosis is extremely important.
Mr. Smith next, and then I'll go up to Sharon then after that. And then move over to further down, then back to CFP. Okay.
Sorry, on the St. Joseph's Raheny situation, it should be borne in mind that because of problems with getting beds in Beaumont, the sleep clinic was transferred over to St. Joseph's in Raheny, and it was funded entirely by an outside agency on a charity basis, where a 5-bed day ward was converted into 3 private rooms. The condition is that only public patients can be treated there or diagnosed there. There are no private patients allowed in. There was a control room put in as well too, and the individual wrote a cheque for 150,000 as a down payment on 3 years' salary for a respiratory scientist to man it, with the promise after 2 years to write a further cheque to meet any shortfall. This was done on a charity basis. The HSE had no input into it at all. Now, what has happened, I don't know, but the sleep clinic was closed down in mid-December. There have been no sleep tests carried out there. And nobody seems to know what's happening. I have written to the HSE.
Can you give us a copy by email after the meeting of that letter? If you
I can indeed, yeah.
Please. Thank you.
In the case of St. Joseph's, I have received a response which has passed it on to another area manager, and I assume something will be done. In the case of St. Vincent's, I've heard nothing. But the situation in St. Joseph's, it's a very effective sleep clinic. The throughput is very, very large, and it is really performing. And to take it off the grid effectively, whereas in the Dublin Northeast area, there's a small clinic in the Lourdes and Drogheda, there's a unit in Blanchardstown which can't get beds, and there's a very small unit in Cavan. That's it. Now we have a situation where all these additional things are coming on stream. Somebody has mentioned to have an awareness campaign. The problem with that is we clog up the waiting list because there's no service there if we have an awareness campaign. You know, it defeats the whole purpose. And this is where the national strategy is required. You asked also about children, and I'll just give you some of the reasons why children get it. Down syndrome is a prevalence of 1 in 1,000 children. And the prevalence of sleep-related breathing disorder, which is sleep apnea, is 70 to 100%. It's a high risk of pulmonary hypertension, especially in coincident heart disease. There's neuromuscular disease. The prevalence is 1 in 3,000. 42% have a prevalence for sleep-related breathing disorder. It's very difficult to detect clinically, reduced life expectancy, and reversible by treatment. There's craniofacial abnormalities. That's a prevalence of 1 in 7,000. Now, it depends on the severity, but it's pretty much 100% chance of them having sleep disordered breathing. There's a condition called achondroplasia, which I'm not probably pronouncing correctly. There's a prevalence of 1 in 25,000. There's a 48% prevalence of sleep apnea. Mucopolysaccharidosis is 1 in 40,000 prevalence, and it's a greater than 90% prevalence of sleep disordered breathing. And it's the Prader-Willi syndrome, 1 in 52,000, is a 25 to 75% prevalence of it. These are hard figures provided by Crumlin Hospital. Now, you asked about the causes of sleep apnea, and again, another thing about our children born. 0.5% of children are born with sleep apnea. Now, how it develops is usually, it hasn't been clinically proven beyond any doubt, but there's been 1 or 2 small studies done that indicate that it's not genetic, but hereditary. And a lot comes down to the craniofacial build of somebody's face, particularly with a receding jawline. Years ago, I was always saying it was obesity. Lose weight and you'll be fine. But there are more and more thin people getting sleep apnea, and it's down to the craniofacial structure. There's also the fact that our tissue within our airway gets weaker as we get older, so it starts to collapse, and it just closes. And this is where we get when we get sleep apnea. Your airway just collapses completely. And this is what causes the cessation of breathing. Now, you can imagine what that does to the rest of your major organs. Your brain goes into a total panic. Your heart starts to beat faster. You're at a high risk of stroke because snorers traditionally get a thickening of the carotid artery. So all of a sudden, you're getting a sudden rush of blood to your head. If there's any weakness in that artery, you're going to get a stroke straight away. So there's so many other things. There's a big pressure on the kidneys. There's also pressure on various other areas, such as hypertension as well. It's not, sleep apnea is unlikely to kill you. It's what it does that will kill you, and it certainly will. We're looking at, if we take the cost of one road traffic accident, which has been costed out by government agencies at 1.5 million, if we saved one person from falling asleep and having a crash, they say 20% of road traffic accidents are caused by sleepy drivers. There are 3 categories of sleepy drivers. One is an untreated sleep disorder, 2 is young, aggressive male drivers, and the other is professional drivers trying to hit deadlines. If you even cut that in 3 and save 1, you could put 1.5 million into this program. That would more than fund it. It's not big bucks. Do you know, it's about getting the right people together, put the strategy together. You know, there are methods of funding these things, but we have to have a strategy. There has to be a national strategy. That's all it is. It's not about money. It's about putting the brains together and getting it together. And it's the same for all the lung health. It's about putting a simple strategy together. That's all it is.
Thank you. Dr. Elise Nazar.
Thanks very much. In answer to a question by Deputy Colreevy about the incidence of asthma in Ireland and the way we rank the 4th in terms of the Asthma World League, the answer to this question is we really don't know why asthma is on an increase. Is it an artifact of better recognition, that we know more about asthma and how to diagnose it? Asthma is unique in that it's an interplay between genetics and environment. So if you like, the genetics would load the gun and the environment would pull the trigger. That's a simple way of putting it. But there are so many other factors and attributes. Obesity, for example, is associated with increased asthma attacks.
But is the rate of prevalence increasing rather than reducing over the last 20, 30, 40
Over
years?
the last 20, 30 years, it is increasing.
Increasing?
Yes. And that's, as I said, probably
and we
because
don't fully understand why.
we don't fully understand that. There's a lot of interactions around us, chemicals around us, you know, the environment that we're living in, air, quality of air, pollution, all this housing condition. Deputy Byrne mentioned something about mold in that. I mean, I'm a pediatrician. I sit in my clinic every day writing letters to city councils to try and remedy a situation where there's mold in the walls and the bedrooms and windowsills and so on. So all this...
Have you spoken with local authority bodies or the structure in charge? Because if what Deputy Byrne is saying is the same, that many of us are experiencing it, more and more people are coming to us with respiratory or chronic lung issues. Surely there's a recognition to be made by local authorities regarding the prevalence of asthma if it's increasing to the level you're saying it is.
Well, absolutely. I mean, all what I can do is obviously, as a clinical person, is to write a letter saying that this will definitely impact negatively on the welfare of this child. It will lead to exacerbation of asthma attack, hospital admission, you know, time off school, parents' time off work, all that. So, but, you know, obviously, as you said, they will look at it and they'll write back saying, well, they don't write back. The parents will come back and say, well, you know, that letter you wrote, nothing happened. And then could you write another letter? And then we have to, you know, all this happens every day in clinical practice as I see it. You've asked a question, Deputy Colreevy, about the 1 in 10 and 1 in 5. So the incidence that we have in adults is 1 in 10, and 1 in 5 children in Ireland would suffer from asthma. This is a little bit of a difficult area for us as a doctor who practice in pediatric medicine, because there are a lot of other conditions, at least in the first 5 years of life, which can confuse the diagnosis of asthma. There are a lot of viral infections can result in symptoms similar to asthma. And in many occasions, we treat them with asthma medication. And that leads to, as they grow older, we hear the common famous saying that, you know, he had asthma, but he's outgrown it, or she had asthma, but she's outgrown it. So yes, 1 in 5, but there is a little bit of a gray area. If I were to, from clinical practice, it'd be probably 1 in 7, 1 in 8, and this would be 1 in 10 later on in life. Professor Crown, you've asked a question about the guidelines. Indeed, in the Asthma Society, we've developed the e-learning program in collaboration with the ICGP, Irish College of General Practitioners. And okay, while the uptake isn't great, we try to make sure that we're standardizing the care of asthma in Ireland. But yes, we need to do more work to make sure that this is filtering all the way down, that the care, primary care or secondary, tertiary care is standardized according to the guidelines. Deputy Doherty, you asked about a very important point of the inequality or inequity in treatment. We have no reason as to why. This medicine, which is called Xolair, just to put it simply, is like a key in a lock. So the key fits in the lock within the cell, excites a reaction, releases a lot of substance that can cause asthma symptoms, the difficulty in breathing and wheeze and shortness of breath. This medicine targets the key, if you like, so it stops the key going into the lock. It's not suitable for everybody with asthma. It's definitely suitable for what we call the severe allergic asthmatics. And in Ireland, according to figures we have, that 450 people qualify for the use of this medicine. This medicine is an injection that's taken on the skin, has to be taken every 2 to 3 weeks, and there has been significant improvement in a study performed by Professor Lane and Professor Costello, which have shown significant reduction in exacerbation, improvement in quality of life. Why is this an inequality? We really don't know, but what we know is that it's not covered by any of the schemes, the HSE, LTI, high-tech programs. So it's not covered by that, and as we speak, one of our adult colleagues in Cork who has 40 patients who cannot secure funding to start them on treatment, 40 eligible patients that they cannot secure funding for them. Finally, I'll just finish and I'll tell you, asthma, it is a simple condition if managed properly. And I'll just quote one of the sayings from one of the parents that wrote about, she lost tragically her daughter, and she said, I wouldn't have thought that my Tricia would die of an asthma attack in a million years. I'm paying a very high price for something I didn't know, and I'm living without Tricia, and that's just a nightmare. So education is key. Education among, all the sectors of the society, but particularly education among the patients themselves. And that brings us to the National Asthma Program, which we would urge really to be expedited, because this is the thing that's going to bring it back to the level of the patient and the primary care. Education, properly resourced program where we have nurses, asthma nurses, because it's been shown time and time again that the role of asthma nurses in management of asthma, particularly in the area of pediatrics and even in adult asthma, is huge.
And the issue regarding the Xolair medication that Ms. Cosgrave mentioned, in terms of that, in terms of the cost of that, have we estimated the cost to the state in that?
Do we have a figure?
Yeah, it's 14,000 per patient per year, and there's we estimate about 250 who aren't accessing it. So I think it's about 3.5 million if my calculations are correct.
And in the context of any further progression in that, has there been any further correspondence or liaison with the HSE or with the department?
The National Asthma Program and the Department of Pharmacoeconomics are actually, they are actually conversing, and there's been to and fro emails and so on. And Dr. McCone, I think, were you involved in any of these discussions with the National Asthma Program?
Well, we're meeting actually with Michael Barry from the National Centre for Pharmacoeconomics early, I think in the next couple of months, really, to discuss it. I know that there's, with his, Pat Manning, who's leading the National Asthma Programme, has scheduled a meeting for us, which the ITS and the Asthma Society, I'm sure, will be involved in.
Okay.
Does that mean when you talk about there are people who are currently receiving the drug, they're obviously paying for it privately and receiving it through their own medical insurance or their own purse? Those who are not, is because of the state? I'm confused. Can you explain that to me? Sorry.
Well, there are certain institutions which are providing providing funding for patients to receive. Well, for example, some of the Dublin hospitals would have provision for that.
So, okay, but I'm just, sorry to be pedantic, that means that the department has actually sanctioned it and has obviously cleared the finance for it to be delivered through the medical system.
For certain hospitals throughout the country.
Are those patients public or private patients?
It doesn't matter.
No, it shouldn't matter, you're right, but I want to just get a picture.
Yeah.
It shouldn't matter, you're correct.
I mean, it's a mixture of both.
Okay,
Public and
okay.
private.
Sorry, is this, excuse my ignorance, is this an oral medication?
No, it's a subcutaneous injection.
Well, I'm sorry not to be rude. You can't, when you're sanctioning the Department of Finances for a drug and you say, Bod's your uncle, you can have it, you can't say you can only have it in 3 hospitals and not in the other 32.
Absolutely.
It becomes a local decision for the hospital itself and its own pharmacy budget. So in Cork, you've got the Mercy Hospital that's sanctioning it, saying we can afford it under our budget. And you've got CUH saying it's too expensive, it's 14,000 a year per patient. So you've got this inequity because it isn't covered under any of the reimbursement schemes, and the hospital can't get a reimbursement for the cost of that. So it becomes a local decision.
Sorry, again, please forgive my ignorance. Is this subcutaneous injection one that people take while they're outpatients?
Well, they come in, have it as an outpatient, be monitored because there's risk of anaphylaxis. So they be monitored for a couple of hours and then they go home.
So just after the first dose or on a repetitive basis?
Repetitive basis, every time.
Every time you take
every
it, you take
3-4
it in the
weeks
hospital?
in the hospital.
Okay.
You know,
If there's a patient in Cork in a hospital that couldn't and doesn't have access to it, could you refer me to Beaumont that does?
I'll
No.
refer to your, or in the case of Cork, if the Mercy Hospital, which you said is administering it, can I then be referred 3 miles up the road to the CUH?
well, as
Sorry, going to go around there.
It isn't working that way in practice.
Okay.
It seems to...
It shows that it decreases the frequency of admission to hospital with complications.
Oh, absolutely, by
I mean,
about 67%.
The problem with the National Centre for Pharmacoeconomics is they take, I believe, not the most nuanced view of the totality of the healthcare costs associated with the new product. They look at the randomised trial, which compared to the other one, and work out how much does it cost, and stick equality on it. But basically, the case you need to make them, obviously, is that this can decrease resource utilisation, and that case may need to be made to somebody other than the NCPE.
Professor McDonald?
I have 6 patients currently on that Solar drug, and I had more, and we've been able to stop the patients because they've responded to treatment. I'm not allowed to put any more on the drug. The hospital is actively trying to stop me using it anymore, not in a nasty way, but basically they're very much aware of how much it costs.
Of cost alone.
Cost. And I've recently been referred a patient who's relocated to the Wicklow, Dublin area from Galway, who's getting it in Galway, and I'm faced now with the issue that I can't start that patient on the drug in my practice up in Dublin, and for the moment I've said, well listen, you'll just have to go back to Galway every 2 weeks to get it, and we'll see how this works.
It's crazy, it's right. Absolutely crazy. Okay, do you want to come back to your questions?
There's a few questions that may fall into my area. First, Dr. Colreevy, just the issue of the social deprivation and the link to respiratory disease is a general one. It's particularly acute in COPD because cofactors with smoking and past history of smoking clearly relate to deprivation, but also the issue of sort of early intervention makes a difference in these diseases, and people from the lower socioeconomic groups have poor access to healthcare. We know that. Also, the other side of the coin is that as you go through life and you've got COPD, you start to fall down the economic ladder by basically getting winter infections, which means that you can't turn up for work, you get passed over for promotion. If you're getting promotion, you lose your job, whatever, you have to go on disability. So it has a social impact as well as social factors promoting it. So that's just to sort of put a line on that. The Deputy Doherty asked me about nihilism, and I may have come across that perhaps I was nihilistic about it. I think there's a huge positive message coming out at the moment about COPD. Mr. McGloin, who's with me here today, has been on oxygen for 6 years, and despite that, he's still the person who's going to take on the running of the COPD support group when we get going for it. But there is an issue. Why have we been so slow to get a COPD support group going? And this has been an international thing. It's not just an Irish factor, but there are very few good COPD support groups in other countries. In Britain, the British Lung Foundation, which is an umbrella organisation, looks after COPD. There is a separate COPD support group in the United States, but it has been a problem. And the factors that go into it are, again, the fact that a lot of the patients are socioeconomically deprived. A lot of them, by the time they're aware of the problem, want to do something, are significantly disabled. These are all issues that feed into it. And there is sort of a little bit of embarrassment. I've known politicians to have the disease who, when you start going at them and saying, would you like to be involved in a support organisation as well? So there is a problem there. But I think it is a huge positive message. The drugs have improved. There are improvements coming along the line. But the COPD tends to be at the bottom of the queue, and we're dealing with real numbers in terms of getting the programme up here. We can sort of say we have 100,000 patients. Yes, we're fairly confident there's 200,000 that are not getting diagnosed, and this comes to Deputy McClellan's point about making the diagnosis. In the issue, we know spirometry is available in some general practices. It's a relatively simple test, but it does require training, and the training goes to practice nurses who get polled to look after all the other issues. And so we have this course running at the moment where we're training people. It's accredited through DIT, and it's European accredited. But we've got a feeling that some of the people do the course and then go back into the practices and get polled to look after the diabetes patients, to look after the blood pressure monitoring, to look after the vaccination, to look after everything else. So it's an issue. And in the COPD programme, we may have to look at something else. But of course, in the current climate, we went for the most cost-effective, cheapest option that was available. But I think some sort of outreach spirometry from hospitals is what we're probably going to have to do. And we know, I think it was Deputy Doherty who mentioned experience from other countries. We know in Scotland that this is how they're getting spirometry done there, is by getting outreach, and it's been done in Denmark and in Holland as well to do outreach facility things. But of course, that costs money. The interesting thing that Deputy Byrne mentioned about housing, and it's just again anecdotally, but I've been looking at disability stickers, request for disability stickers for patients who've got bad COPD, can't park and so on, and Dún Laoghaire Council were not giving them on the basis of lung disease for a long time, so you have to sort of write letters and put in a degree of hassle, whereas if you put down cardiac disease, they automatically got it. So that's the sort of thing we're facing with in terms of respiratory. That's not just most of those patients looking for disability stickers would obviously be COPD patients, but respiratory disease in general suffers from that lack of problem.
And has that mindset changed, do you think, sufficiently?
I think the recognition, this is an issue why we need a specific support group to do that sort of thing. If you find an issue, it may be Dún Laoghaire. I think I probably battered them down in Dún Laoghaire at this stage, but what's happening around the country? If you're in Limerick or Galway and you're looking for a disability sticker, does the local council person who gets all these requests, some of the requests that we would get, and from being public representatives, some of the requests you get are just not sustainable. But when you get somebody who's got genuinely marked disability from COPD and they're not getting a sticker, I'm sure a lot of hard-pressed doctors and healthcare providers would just say, cardiac, go and get it. Put it on the letter. That might be happening. But, the COPD support group, which hopefully we'll have up and running, will address that, I think.
Okay, thank you. And Mr. Watt?
Thanks, Kieran. Just to answer some of the questions in relation to cystic fibrosis, Professor Crown raised the issue about access to beds in Vincent's before Christmas there, which our association raised in the public media. Well, it just reflects it's a good example of how effective the work of this committee can be, because I think calling the management of St Vincent's in to account for their actions around that was very, very helpful. And I'm glad to say that since the issue was raised by our association and by the committee here, that there has been no problems in Vincent's, and people have been accessing the beds. And as to acknowledge Dr. McCone here, who's played a very important role from a clinician's point of view, ensuring that's happened. But we'll monitor things very closely, and we're not complacent about the issue at all. In relation to Deputy Doherty's question about the Beaumont inpatient beds, we're glad to say that Liam Duffy has agreed, and Beaumont has agreed to put the number of beds into the service plan for the hospital, the development plan for the hospital. But we very much welcome some sort of letter from this committee to the RDO and the hospital saying that this is a priority. So if that could be done, that would be very, very helpful in terms of trying to get some momentum to that, and acknowledge Dr. Jerry McIlvaney here, who's played a leading role in pushing this issue as well. He's a CF consultant in Beaumont, but that would be very helpful in pushing that. In relation to health promotion and donor awareness, I think Deputy Byrne makes a really important point. Donor awareness is left to the NGOs, the Irish Kidney Associations, ourselves. there's virtually no support from the HSE. In England, you see ads on television, including, encouraging organ donor awareness. There's a national register where you can donate your organs online. None of that exists in Ireland. It's a disgrace, to be honest. It's not as priority.
We hope as part of a work programme to look at that later in the summertime.
Brilliant. We'll come back to you maybe wearing a different hat on that. But also to say too that in terms of Love Your Lungs as well, I mean, I think the point that Deputy Colreevy and Deputy Doherty have made in terms of not seeing that programme, it's because it's left to ourselves. With no money, we're trying to do things in buzzwells. There's virtually no interest from the HSE and the Department of Health, never mind public support.
How do you mean there's no interest in the HSE, the Department of Health?
Say again?
How do you mean there's no interest?
There's no, I mean, it's been raised with them and, we're saying we're doing this, would you like to come on board? Will you put it on your website? Would you even give us some minimal resources for this? And there's not even a, basic interest around it, in terms of, it's something, we're doing the job basically of the HSE. I mean, it's completely and utterly unacceptable, their approach, and, we really asked for this committee support to the HSE and Department of Health that they would give substantial support for this programme over the next while. Even if we do all the work, if they at least support it, it's a kind of a no-brainer. But I think the bottom line, I think it should be expected. So those are the issues I would say.
Okay. Sorry.
Mr. Connor might be able to answer this as well. Who in the department? Who is the clinical lead in the department for lung, in the HSE for lung-related issues?
And I'll bring in Deputy Colreevy now to stage as well.
Just two issues, and it's not questions for the people here today. I think I always understood that one of the foundation principles of the HSE, an underlying principle, is that access to healthcare is based on medical need, and it's not based on ability to pay, or it's not based on geographic location. Now we learn that access to healthcare is based on need, geographic location, and hospital pharmacy budget.
That wouldn't entirely be correct, now, to be fair.
I think we need urgent clarification from the department.
That would be a misrepresentation, now, to be fair, of the policy of the HSE, to be fair to the HSE. We're not here to defend themselves today, but that wouldn't be exactly fair.
If we have evidence here today that depending on a hospital's pharmacy budget, required medication is or is not been made available.
Well,
we need clarification.
What I was going to suggest in my closing remarks is that we would, as a committee, take this issue up with the HSE, and we can place on the agenda Deputy McLellan or any other member, if it's from your party, can have a question to the HSE as part of the quarterly meeting on this particular issue.
I also think that the point that Mr. Watt made needs to be addressed and addressed seriously, because it's wrong that people who are effectively doing the work of the HSE do not have the active support of the HSE in doing that work.
Just ask that question. What is it the HSE are not doing for you? In the context of your remarks, if I please, just to flesh it out.
I just want to make a comment really, because I think this gives you a sense of the challenges that we're facing. We've presented to you the data, the importance of lung disease, and I think that was been communicated very well. The HSE have a health promotion strategy document that's recently been published. It talks about the crises, the public health challenges that are being faced by the Irish government, and there is no mention of lung disease in it. They talk about coronary artery disease, diabetes, obesity, a variety, and they talk about smoking, of course. And I think that that's what we're trying to get across here, is that smoking will impact respiratory disease, but that there's a substantial morbidity that is not related to smoking. So we do need advocates. We need advocates to go to the HSE and say, where is respiratory disease when you're making these policy documents? Focus on it, have an independent approach to it, so that we can work on trying to improve outcomes for this huge patient population. I mean, 1 in 5 is the numbers we've been hearing repeatedly here. And we need to really advocate to try and get the HSE to recognise that and to work with us to try and develop a strategic document to move forward.
Mr. McLean, you want to get it?
Well, I just, what I'd like to lobby for would be a lot more awareness of the COPD. Because as we discovered, awareness is the key to getting you know, to get the word out there. And like, you could go on the street now and you could ask, I'd say 10 people, and you'd find that maybe 2 might have heard of it. So awareness. And also on the, it was brought up here by Professor McDonald here, the outreach. We don't have outreach in Sligo, but it's rolled out in 12 hospitals around the country. And I know from my experience of meeting people who are involved in an outreach program that it does work. And I mean, who better to know? Like, I mean, I'm a patient myself, and rather than be in hospital for 10 days, you'd be quite happy to be at home because you're in your own environment and less chance of picking up hospital bugs and so on like that. So I would push for that and help with more pulmonary rehabs around the country, because they're only spotted here and there, and I mean, I have gone through 4 of them now, and they definitely work.
Okay, thank you. Any other person want to make a contribution, or President O'Donnell?
Just, I think there was the question about what the HSE is doing in terms of respiratory. It's got a number of programs in the clinical program devoted to respiratory. There are 3. There's one in COPD, there's one in asthma, and there's one in cystic fibrosis. But that's 3. There's gaps there, as we've heard today, for other areas. We haven't heard about the issues that related to sleep. We haven't heard about anything related to interstitial lung disease. There's nobody here today representing those. There's nobody here today representing tuberculosis, which is another area. And again, going back to Deputy Colreevy's issue, again, a disease of deprivation that perhaps hasn't had the attention it merits.
Okay. Can I thank everybody for coming in, and thank you for your presentation. I think it was a very interesting, worthwhile, challenging part of our process of meetings as a committee, and there's a very clear message has emerged from our meeting today, and not least it was the fact that we have to have a clear strategy and a joint approach from the Department of Health and the HSE, and also that we must tackle the stigma that it's the disease of the deprived or the poor. That's certainly a message, and also that there is a need to, as members have alluded, to change the mindset that respiratory disease or lung disease or illness is because of smoking. It's an awful lot more than that, and we need to really change that message. But can I again sorry, Deputy.
Sorry to interrupt you, and I don't want to assume, just in case we leave here and I'm making a wrong assumption. Are we agreed that we're going to send a letter to the Department?
I'm going to make that next point, if you may.
And also, can you include the RDO then of the Dublin North East or D&E with regard to Bowman Hospital and the 13 beds, please?
And my final comment was that we would, if the meeting would agree, that we will take a number of issues in terms of the sleep apnea with the HSE, that we will also write to the HSE in the proposal that you just made there, in terms of the medication, and that we'll communicate with the department and the HSE on that. And thirdly, that we will write to the RDO of Dublin North East regarding the beds in Beaumont. Is that agreed?
Agreed.
Okay. Any other business? And can I also, my apology again, thank you for this morning as part of our process, and just to commend Senator Burke, who's suffering from sleep deprivation this morning.
That's right.
From being here.
Same problem as junior doctors have, you know.
Thank you.
Very quick straw poll of our guests. Would you, in general, be in favour of the idea that the national parliament's precincts should be inside and outside the smoke-free zone?
That's not a question I'm going to allow you to even attempt to.
Would anybody like to say no?
Not least because a number of members. Not least, Senator Cromwell, because a number of members of the committee might feel free to interject. But can I just very sincerely, on a very positive note, thank everybody for coming in this morning and for your presentations. I think, as I said, it'll be part of a process that we'll engage in. Senator Cronin has been very active in promoting a different strategy about how we see life, and that's challenging members of the committee. We're adjourned. Just to remind members, sorry, before we adjourn, that next Thursday morning at 9:30, Operation Transformation personnel will be in the making a presentation to the committee as part of their television programme. So members, and that, Senator Burke?
Junior doctor issue, as I raised it.
We have a correspondence which was too late for today's meeting,
right.
Which will be discussed as part of a strategy to have hearings on the issue of the NCHD, hopefully before the end of May, if not sooner. it's a question of finding time in our calendar to do that.
But I thought we agreed that we would have it on a Tuesday in particular.
We're hoping to do that. We have a number of imminent bills coming to us, but it's a question of getting together. And if you want to talk to the clerk afterwards, in terms of, we had correspondence from Shirley Cooter, who's the Assistant Director of Industrial Relations for the Irish Medical Organisation, which was too late for the meetings this morning. It will be on the correspondences for next Thursday, and we hope to put in place a strategy to work on this. And if you have any suggestions between the meetings, you can talk to the clerk.
I'll do that. Thanks, Chairperson.
All right? So we stand adjourned until 9:30 next Thursday morning. Good morning.